Hey, everybody. Welcome to another episode of the Med List. I'm Kevin and this is Donna, and we're really excited to be here today for lots of reasons. One is I had a really good conversation with our producer, Tim, and I was telling our guest and Donna right before the show, what really matters about doing a show like this for us. And I think lots of great information is out there. Lots of great information that you can read and you can retain and you can hopefully regurgitate for your success. But the thing that really reaches folks is, the emotional connection. And I can't think of a better emotional connection than somebody's son ending up having an emotional connection. So a huge congratulations to the Bartlett family.
Yay. Yeah, so shout out to my son Chad and his fiance Brooke. They just got engaged this weekend, and man, are we excited. So yes. So
Oh,
hi Chad and Brooke. I think you're listening tonight. So thank you so much.
oh,
Love you both.
that's so super exciting. And I think the one thing that with any marriage, any good marriage, I think the connection point is trust, Donna. Would you agree?
Oh,
That's
yeah.
the biggest piece you can have between husband and wife that's going to matter to hold the years together.
Yeah.
And I don't think it varies all that much between you and your healthcare team. Like that kind of trust, that building the relationship to have trust over time is the most essential component. That's one thing that I've really valued with our guest that's coming on board that you and I have known for a while now is just being very real and transparent and trustworthy, is something that he covets, within the relationships that he's formed over time. And I think that trust coming back into healthcare is one that it takes some work, to do it on both sides of the party. So I'm really excited to bring on our guest for today and talk about just that.
And we are so excited to have you here today, Dr. Donnie John. So thank you so much for being with us. And I would love to share a little bit about you with our viewers and our listeners. So Dr. Donnie John is the executive director of Nova Script Central, an award-winning nonprofit charitable pharmacy that provides life-saving medications and health education to uninsured patients across Northern Virginia. His career reflects a deep commitment to advancing healthcare access and equity through his work as a healthcare professional, patient advocate, consultant, and social impact entrepreneur. Dr. Donnie John is also a leader with multiple national and regional boards, including the National Minority Quality Forum Advisory Board, the Mid-Atlantic Kaiser Permanente Research Institute Community Advisory Board, the National Association of Free and Charitable Clinics, and the Virginia Association of Free and Charitable Clinics. He also co-chairs Region 3 Mid-Atlantic Regional Health Equity Council and as a national co-chair of the Kaiser Permanente Research Bank National Community Advisory Board. In all of these boards, your work is profound in what you're doing and the people that you are helping. You were also named one of the 40 under 40 thought leaders in health by the National Minority Quality Forum in 2017. That in itself is amazing. He was honored for as a finalist too for the Center for Nonprofit Advancement's Chief Executive Leadership, known as Excel. And I just want to share a little bit more about Nova Script Central, that it was founded in 2007 and it's delivered over $231 million worth of essential medications to uninsured residents in Northern Virginia. And Dr. John and this organization expands its services to include free education, health education workshops, and school-based immunizations, substance abuse therapy programs also. So in just really working with the most vulnerable in your area. So thank you for the work that you're doing, Donnie, and welcome.
Thank you. Thank you for having me, guys.
Yeah, it's good to see you, buddy. And I think like any fairy tale story, modern fairy tale story, Donnie and I started dating on LinkedIn. I mean, we didn't get to meet each other in person. We were just following each other there. And it's funny how many relationships start that way. I mean, real relationships that are so meaningful is just a social media connection with you, Donnie. I mean, you got so many things that you're doing, bud. A lot of things that I deeply respect. A lot of hills that you have to climb that are just really difficult. What gets you up in the morning to do it every day, bud?
I wake up thinking about how do I help make things better for those around me, because we're blessed to be in the positions that we're at, and we have the power of influence. And as healthcare professionals and leaders, we have to think about how we make life easier for our loved ones. And my framework is always, how am I going to become the best chief patient advocate for myself and my community? And no matter what I do, it's always thinking about what are our opportunities to remove barriers, anticipate the barriers, because all of us has faced challenges and struggles. We have felt helpless when it comes time to access healthcare. But when you're able to work behind the scenes and you could think about from a large scale, can you make impact? Can you make things where it's easier to fill out paperwork so you don't have to do a prior authorization? Can you figure out hospital access, language lines, and make sure that patients have people that speak their language when they're coming to see you at a medical facility, in a hospital, a federally qualified health center, or a retail pharmacy? Those are the type of things where you just have to think beyond yourself and really how can you have a positive impact.
Right. I would love for you to share, Donnie, just in general for our audience, just in general, what is a nonprofit pharmacy? And what is it that you do that's different than a regular pharmacy that maybe the majority of people are going to? So if you could just explain the work that you do.
Sure, it's a great question. So nonprofit pharmacies operate in a lot of different models across the country. Everyone is set up a little differently, where some are going to be closed door pharmacies, which is so my organization is a closed door pharmacy. So we ship the medications out to the clinics, to the patients that are seen at the clinics that we're part of our network. Some are direct, patients can walk into the pharmacy and gain access right away. Others might also ship medications out. They might have more one-on-one consultations with patients. So everybody operates differently in terms of clinical services they provide, the formula that they serve, that they have on hand, uh, and the staffing models change also. Hours of operation are different. Whereas a traditional pharmacy, you walk into a big box retail chain or an independent pharmacy, they have their set prices, they accept insurance. Most charitable pharmacies don't accept insurance. It's all cash or it's free donations. Like they don't accept the cash from consumers. So also with the cost of the medications, it could be severely discounted because we're able to get medications donated from different suppliers, and then we're able to pass that savings on directly to the consumer. You know, some provide specific, clinical pharmacy services. Like we provide a lot of health education out in the community directly. We also do school-based immunization work. So we just don't operate like a traditional pharmacy. We're out in the community really being proactive in the work that we do. But there are a lot of great charitable pharmacies across the country doing amazing work in their communities, filling the void that's there. So when you hear about pharmacy deserts, medical deserts, there's usually a charitable pharmacy or a free clinic that's in that neighborhood that's been there as a beacon of hope, serving the people most vulnerable around us.
Yeah. So just curious for, maybe some of the pharmacists that are out there too. And, we all have had patients in our world of when in our dispensing days. And I know, people struggled and like, I can't afford that. I can't pick that up. Or when people were changing from Medicare and when Medicare Part D came about in 2006, there was really like a lot of big, huge learning curve. And a lot of people were, kind of lost in the shuffle, if you will, as to what are they supposed to, what's this Medicare Part D thing? But also there's that transition when people are on Medicaid, for example, and then they become Medicare or dual eligible. And then sometimes there's a little bit of gap in coverage there too. So just thinking about those different times or different times in life when, gosh, you just don't have that money to pay for a prescription. Does that qualify people for something like this, or what are the qualifications? Or as a pharmacist, how do I know, like, oh, here's this nonprofit that you would benefit from? Is there
Yeah.
an easy way to figure this out?
So that's a great question. Most charitable pharmacies usually have a FPL, a federal poverty level income requirement, meaning that if you meet 100%, 200%, 300% that level, then you become eligible as a patient to get medications from that institution. So every location is different in terms of, just like the free clinic has different care requirements where you need to be a resident of that jurisdiction, meet the the FPL limits, show the paperwork, then you can get services. For our pharmacy, patients have to be 300% below the federal poverty level and has to be a patient at one of our 16 partner clinics. So throughout Northern Virginia, we have 16 clinics with 33 locations amongst them. Some are hospital system locations, some are federally qualified health centers, some are standalone free clinics. So as long as you're a patient in one of our partner clinics and you meet the financial threshold of 300% income level, then you're eligible to get medications from us. All of our medications are $5, regardless if it's a brand name or generic, and up to a 90-day supply, we'll give it out for $5. And since 2021, we've been able to provide insulin for free to patients in need that are patients, once again, at our partner clinics.
Wow.
And so having a closed network, because we do get audited by the pharmaceutical companies and places that donate the medications to us, we do have to verify eligibility. Just like any charitable pharmacy that's operating across the country, they do need to verify paperwork. Same thing with the clinics that are providing free medical care. If you go to a hospital system to get charity care, you have to show documentation. We can't just take your word on it, because we want to make sure the people that are most in need of care are receiving the appropriate care that they need. But there's a lot of scenarios where, when we had during COVID, a lot of people lost their jobs. So we went from having a huge uninsured population we were serving to now having an underinsured population, people that now had no opportunities to get care because there was no access. So they've come in and meet the needs within our clinics, and then we're able to serve them accordingly. So there's a lot of life moments that happen where people will lose their jobs, people are transitioning, and they need help. So charitable pharmacies, as I mentioned, are different across the country, but all of them will work to make sure that they can serve the community the most appropriately way possible. And a lot of that just requires having the right paperwork and process, and talking to the people most in need, and just knowing the resources around you.
Right. And just to be clear, and I'm trying to pull up the 2025, but when we talk about federal poverty levels, I don't want people to think, because so many times when I was in the outreach program, people would say, oh, I don't qualify for that. Or, oh, I'm not that bad, for things like that. And I think people are surprised as to what qualifies folks at different federal poverty levels. So it sounds like worse than it is at times.
Yep.
But when we're talking like 300, 400 percent poverty levels, these are good incomes for, a lot of households actually qualify for this assistance. So I want people to think about that, and not necessarily think oh, it wouldn't be me. But it very well could be, because of the it's probably more money than they think to qualify.
Yeah. And when you look at the FPL, you also have to think about some of these medications, like the specialty drugs, they're really expensive. So if a treatment costs $100,000, like the hepatitis C drugs when it first came out, cost $100,000.
Yeah.
Regardless of your own income, not many of us can afford $100,000 for a treatment, right? So having the eligibility requirements of, do you meet the financial need? So it's kind of like financial aid when you go to college. You have to fill out the paperwork and think about what's the need that you have, and then do you qualify? If so, how much aid do you get? The same way there's patient assistance programs and all these other things that, based on your income, it qualifies you for a service. But the federal poverty level is just like the national standard, where everybody knows this is a threshold. And the numbers vary based on, if you're a single person, a family of 4, family of 5, 7, and so on. But there is a national standard that gets changed and updated every year based on, what the federal standards are. But every institution and locality can have more flexibility in how they want to interpret it. But usually the FPL, the federal poverty level, is kind of like the base. And then people make adjustments based on how they feel their community needs help.
Yeah. So it's for any adult too. It's not just for, a certain age necessarily. It's adults and their families. So it's not just older adults that would qualify either.
Yeah. So for example, one of the cities in California, you can make $100,000 as a single person and qualify for Medicaid. Exactly. And so if you think $100,000 in most other parts of the country is a lot of money, but given the cost of living and the prices in California, in this one municipality, $100,000 qualifies you for additional assistance, because housing alone is just insanely expensive.
Right.
So there are a lot of benefits that people don't know. We just think that we may not qualify, but it's a matter of asking the right questions. The worst is that they can say no, but there are a lot of programs out there that are willing to help you, to find the answers and to navigate the right way.
Yeah, that's great.
Why is it so confusing, buddy? Why is our system so confusing that we can't find any of these answers, and so many people feel like they don't know where to go or where to turn or what benefits are there? Do you feel like it's a purposeful design? Do you feel like we don't have the educational resources? Like, give me the wonderful crystal ball that I know my friend Donnie has on how do we solve the confusion? Because the fact that there are so many resources out there that folks don't know about, that's not a good thing in general. Like, we are struggling as a society to stay healthy. So how do we connect those dots, and why do you think it is so confusing right now? How do we remedy that?
So I'll answer the second part first of why things are so confusing, and then I'll go to looking at possible solutions. The reason why things are so confusing is there's profitability in the chaos. So when you look at the supply chain as to who how is money being made in the healthcare system? Our system is incentivizing for people to get last minute care. We don't focus on preventative care and make preventative care accessible. Now, after the Affordable Care Act, we have transitioned to this value-based care mindset. But we spent all these decades really focusing on acute needs, right? An accident happens, then we're going to fix it. Versus let's focus on wearing the seatbelt to prevent the accident and lessen the damage. So it's kind of, we're going backwards, trying to figure out how to fix the system. But that profitability and chaos, where when you have too much of use of a certain resource, then that impacts the bottom line. And so the profits are a big part of it. But there's no reason why we can't figure out a system where we can win altogether, where we can get good outcomes and we can save money and we can still be profitable. It's just a matter of thinking about the business case. What is the business case of doing the right thing? And oftentimes we're very emotional. We want things to be free, like all drugs should be free. That's not realistic. So, instead of having these ideas that are, fairy tales, let's think about functional things. Let's sit at the table and think about three things: accountability, accessibility, and affordability. How do we make sure that care is accessible, and then make sure that it's affordable, but then accountable, meaning that the outcomes that you are paying for and you're getting access to are the right outcomes? Because right now the accountability is lacking, and it's also accountability both ways. As consumers, we have to be accountable for our actions and make sure that we're proactive in our care. Then as a clinician, we have to be responsible for making sure the care that we're delivering is appropriate. So that incentive model has to line up. And I think we're slowly making a shift. We are looking, now that we have less resources in terms of with different financial situations impacting a lot of people across the country, people have to look inward. They have to make hard choices. But as healthcare professionals, we have to do a better job of being more informed. That starts in schools, where the schools have to really teach students from all disciplines how to find resources. When we talk about people want to subspecialize, I want to be a super clinician, I want to do oncology. So I ask every single person that tells me, I want to go to oncology, Dr. John. I'm like, great. So tell me about how are you making patients afford their oncology treatment? They're like, what do you mean? So the number one reason for personal bankruptcy is medical. So there's something called the financial toxicity when it comes to cancer treatment. Tell me about it. What do you know about it? They're looking at me like, well, the guidelines tell me that these are my three choices. I'm like, that's wonderful. But if a patient can't afford the treatment and they go into bankruptcy, you're not answering their question. We have to look at why are people less likely to seek care in the first place. And it's usually the financial constraints as to, can I afford treatment? I was on a panel a long time ago with a representative from a pharmaceutical company, and he was telling me that in certain parts of the world, there's cancer diagnoses are made very easily. They have all these screening tools, but people are refused to go get screened because they rather die not knowing than die knowing that what they needed to get better was on Mount Everest, meaning it was so financially out of reach that every day they're going to die a little bit slower because they know that if they were just a little wealthy, had a different circumstance, then they can afford that treatment to help their situation, versus them just dying not knowing, then they're not living with that agony. And it was a really profound, statement when I heard it, because I'm like, it makes so much sense, because here we are trying to get people to go proactive to get care, get screened for cancer and all sorts of stuff. But then when you look at the cost of treatment, we don't factor that in as a big motivating factor of why people are hesitant to seek help, because we have so many other financial obligations. Is it food on the table, a roof over our head? Medications tend to be the last choice because we're trying to take care of all the other needs.
Yeah.
I think there's something really interesting inside of those aspects you just mentioned there, Donnie, and that's we oftentimes don't consider behavioral economics in our decision making, right? Both as clinicians and as individuals that are making those financial decisions. So a big driver in behavioral economics is just really, why do I make the purchasing decisions that I make? What's the psychology behind those decisions? One of the major concepts is loss aversion. So one of the biggest drivers is we don't want to lose, right? There is a bigger drive to not lose than there is to win. And so in healthcare, I'll give you a personal example, which is, I'm sure you guys have all heard, and Donnie, you have to stop me if I keep using this example, but I feel like I have to. I'm an individual that have been very blessed that I've had a job. My wife has a job. My wife has insurance. I have insurance. I went to a trampoline park, was the biggest kid there at the trampoline park. I jumped up on what I thought was a platform. I fell from 4 or 5 feet in the air onto like a metal bar. As soon as I hit the ground, I thought, 1, that hurt. 2, dear Lord, I hope I can move and I didn't hurt my back significantly from the fall. And you know what the third question that went through my mind was, Donnie? How am I going to pay for this? Where am I going to go to be able to avoid the cost of this? And I thought, I can't imagine patients going through that exact same thing all the time for all the decisions that they're making of going, do I get groceries for my family? Do I do X, Y, and Z other things? Or do I pick up this prescription? Or do I go to the urgent care that my doctor told me to do because of those financial decisions? When it comes to that triage, and thinking about loss aversion and thinking about how brutal it is to think about the devastation of medical debt, where do you think the first thing is to start? And what have you done with your patients, Donnie, when it comes to those folks that are saying, I don't know where to turn because it's just so expensive? Where do you place them first so they can be more successful?
So I think the first thing is trying to get them to understand their needs, understand their disease. Because we talk about here's all the treatment, here's all the resources, but it's like, let's take a step back. Are we making sure people feel comfortable with the information? Because it's overwhelming. So when you're in medical crises, there's a lot of thoughts, like you just mentioned, that go through your head. So you can't think straight because you have so many different things. Is my wife going to kill me for jumping on the trampoline? Who's going to take the kids? Like there's all these factors that, as dads, we have to think about. It's like, my wife is going to kill me. So once you get back to the reality of stuff, you really have to look at where can I go, how long it's going to take me, and all these other factors come into play. But the more we focus on prevention, like how do we get healthy? If you have diabetes, do you understand why certain steps are needed in order for you to see a certain health outcome? If we can, I always talk to people about no one chooses to be sick. They just need help learning how to heal. Right. And that's what we have to focus on, sharing the knowledge of how do we get you healthier? What is it that you need and that you don't understand? Taking that time, because they may have gone through years of having an illness, but no one's really taken the time to sit down and explain to them. That's why health literacy and cultural competency are two big things that I've focused on throughout my whole career. Is more of how do we make sure people understand what's being told to them, but how do we make sure that we're putting it in terms that they understand from their cultural beliefs, whether that's cultural from an ethnic standpoint, cultural from a regional standpoint. So if you grow up in the South versus the Northeast, two different cultures. If you grow up in even the same state, two different cities, different cultures. But just knowing the nuances as to what's the environment look like, what shapes the individual to be them, and just really observing it. So I think those are the most important things. First is just really ask questions and understand who you're trying to serve, and then figure out how do you help them based on their needs. Because we can tell you this is where you need to go, but what happens if you have no transportation?
Right.
That becomes the biggest challenge of, well, the nearest hospital is 50 miles. Oh, just go there. They have urgent care. They're open all night long. You could just get a visit. But okay, how do I get there? We'll call an Uber. I'm in rural America. There's no Uber that's going to come out here. I have no cell service. So what would you like me to do? Those are the type of things that we have to really be cognizant of. What are our community member situations, and how do we really help them based on what's fitting based on their needs? We can't just make assumptions. We really need to think about the core things of, can we make care accessible? Do we help them understand once they get there? Do they know the right questions to ask? When they go home, do they know what to do as a follow-up? So it's not a simple thing of like point them in all these different directions. It's more of taking the time to help them understand the situation and really figuring out how they want to have care received. Sometimes they don't know, because just, you don't know what you don't know. So take the time to explain, here's your options. Based on what you've told me, Mr. Jones, here are some ways that we can work around it, right? Because there's always different resources out there. And sometimes what happens is that resources are really well established in the beginning, but then people don't use it, and then it goes away. And then people say, well, we did this project, or we tried this, but no one used it. And then I ask, well, how well did you market it? Did you put it in other languages? Did you really communicate to the community? So sometimes it's kind of, well, we're doing this to show that we're, having a good public face, but then we're not going to market because we don't want anyone to use it. And then we can say, we're never going to do this again because, it didn't work. It's more of being intentional in your design and how you want to provide care. And, the empathy goes a long way in terms of designing care, care systems. And that's where we're starting to see some great leaders across the country that are really focusing on having that high emotional intelligence and really looking at how to make sure that care is delivered in the most respectful way possible.
I have so much that I want to talk about, but I'm going to pick this one thing and then more to come. But when looking at education, because you went back to, what are we teaching people that are in healthcare, that are learning healthcare, no matter what the discipline is. So I'm part of an interprofessional group that we have many different disciplines working together. What was really neat in Massachusetts at the UMass system is there's a system where they're able to access whatever somebody needs, whether it's food, and do they qualify for food stamps? If it's transportation, what's available to them for transportation? If it is cost of meds, going through some of the foundations or various needy meds is a great website too for people in general. And so teaching the med students, the pharmacy students, the nursing students, all of these areas. So they actually had to go in and work up a patient and be able to find all the different services that this person needed and use this particular platform in order to do that. And how great to have that available. So if you are within those institutions within Massachusetts, you can go in and find this information. So like you're saying, it's out there. Where do we find it? And it is up to these health institutions, most likely, I think. And I think it's a great use of resources in order to provide that overall health care that someone needs, that whole person. And then Kevin, even where you're working now in the medically tailored meals, that's really important too, and looking at that. So I think we are coming around with more of those services. So I just want to touch base that there is some of that, and I like where you were going with that, Donnie, in knowing that that is available and I'm helping to teach in that area too, which is pretty exciting. The other area is deprescribing. So I really want to ask you about this. Does your nonprofit or do other nonprofit pharmacies, do they concentrate on deprescribing? Do they concentrate on reducing unnecessary and inappropriate meds and really try to do that, not only advocate for the patient, but really working with the providers and going through and doing med reviews and being intentional with reducing costs that way?
Yeah, no, it's a great question. And, we do focus on, reducing the pill burden on patients, reducing polypharmacy. One of the things that most of our patients have multiple comorbidities. They usually are on like eight or more medications. So before I fully took over as the executive director, the measure of success in charitable pharmacy space was how many drugs are you getting out there? We drugs. I'm like, so is the goal to get somebody from 8 drugs to 10? Is that our measure of success? Is just increasing the pill burden on somebody? Or are we looking at reducing their health expenditures and looking at quality outcomes long term? Because I went from nonprofit to for-profit quality improvement space to nonprofit. So implementing the Affordable Care Act across the country, looking at quality improvement, value-based care models, going to the nonprofit world where it's like they should be happy they're getting some care. It's like, wait a minute, regardless of where you are, everybody deserves quality care. And in the charitable pharmacy space, we do sit down with patients to really look at what are all the medications. Why are you on 5 blood pressure pills or multiple diabetes medications? Can we ease the burden? And we talk to the prescribers to kind of educate them that here are some options that we can work with this patient to reduce their medication need. Because the goal should not be to increase the number of medications they take, but really ask, are they taking it? Do they understand their illness? We had done a project using it was called All Phase. It was a hypertension management protocol piloted by Kaiser Permanente, and we implemented that at 2 of the fairly qualified health centers, and we saw tremendous success. We screened patients to figure out who's high risk for cardiovascular disease and with diabetes, and we put them on a specific regimen, identified patients to the providers they prescribed, we tracked their lipid panels, all their clinical outcomes, and we had really good success with that. So there are multiple different programs across the country that different pharmacies are doing to really look at quality improvement, driving patients to be on the most appropriate regimen. At the same time, we focus on sustainability of affording that medication. There is no reason why someone needs to be, bless you, on the most latest and greatest drug. It's focused on what can this patient afford once they get a job. Because if I put you on the newest agent that's out on the market for, say, hypercholesterolemia, is that patient going to be able to afford it when they get insurance, or if they get insurance through the ACA exchange? Chances are not. So we look at, ignore the commercials. Let's look at what's the most cost effective that you could stay on that medication. Because having worked on the insurance side, telling me that you took all the samples and you had tremendous success is not going to win the argument of getting that drug approved. There's a reason why they have different, step edits and all these things. And I didn't really understand all that until I went into that world and seeing behind the doors of how insurance works, whether it's from a pharmacy perspective or a medical insurance perspective. Understanding that behind the scenes is not something that everybody gets to do. But that's why when I'm in this position where I'm at right now, from an advocate perspective, it's more of you understand the system and you figure out how do you make efficiencies where you know that the challenges are going to exist where patients can't afford the drug. Can we focus on what's covered by Medicaid? Because most of the time, if the drug is covered by Medicaid, chances are it's going to be covered by commercial insurance and other places. So when we look at sustainability of access, we have to look at the most cost-effective drug. Yes, you may want to have this brand new drug, like everybody wants a fancy car, but not everybody can afford Lexus. You need the Toyota. What's going to get you what you need to do that's going to be reliable and get you stable. And let's figure out how to get you off of the medication. That should be the ultimate goal. So everybody does things a little differently. One of the things that we just launched recently was we created a medication adherence log, a medication consumer log, and it was the first in the world that's translated to 10 different languages. Because what we noticed working with all the diverse populations that we serve is that people don't understand why they're taking their medicine. They don't understand the name of it. I take something that's yellow, Kevin. It's also done a pink tablet shaped like a star. Do you know what it is? Of course, there's only 5 pink tablets shaped like a star that I'm aware of. But we had this, we translated it, put it on our website. It's free for anyone to access. But no one really took the time to redesign the consumer medication log because usually it's small font. It's very hard to read. But we used icons. We looked at how do we improve the literacy and competency. And it's just these little things that having that experience, working directly in the community, knowing what will resonate. And we always think about designing based on our family members and our needs. We look inwards thinking about how would this help my family member that's struggling with adherence or needs help with stuff. So when we design and we translate, we're always thinking from that early design phase, how is this going to be used across different groups? Instead of waiting till let's just do English and let's think about people that speak Spanish or other languages down the road. That's part of the value of having a very culturally diverse team. I'm blessed to have a very good team of talented individuals that are all from diverse backgrounds. So when we think about these things, we truly reflect our community and we put our family's perspective into the work that we do because we're really looking at, will this make sense for my family member? When they need to learn how to plan discharge from a hospital, what to anticipate. We create educational handouts based on that process. If it's how do you get prepared to go to a doctor's office, a doctor's visit,
Right.
we translate it into all these different languages, looking at from a family member perspective, because we've all been caregivers. We know the challenges. We know that some people don't feel comfortable asking certain questions. They don't feel comfortable knowing the post. Well, you have to go to these 3 specialists, call these 5 numbers, and you have to show up next week. It's like, okay, that's a lot for any one of us to handle. So just imagine somebody that's new to accessing care. How does that work?
Absolutely.
Yeah, I love that. And I've got a couple questions for Donnie and really want him to dive into how he's going to help the audience on a couple understandings of one, what is this Lexus Toyota world that he mentions there? Also diving into that cultural kind of component. But before then, wanted to share a message from our partners over at Remedy Chain.
At Remedy Chain, we know throwing away perfectly good medicine feels doubly wasteful. It's bad for the environment, and it could have been used to help a fellow human in need. So we found a remedy. Now you can donate your unused meds. Our pharmacists inspect and certify every donation so it can be safely and legally redistributed to vulnerable patients. Visit donatemymeds.org and click the Donate Meds button. Unopened, unexpired medication in original packaging is eligible for donation. Open bottles, controlled substances, and temperature-controlled meds are not eligible for donation. Once confirmed, we'll send a donation form to sign and prepaid shipping instructions. And we'll let you know once we've matched your donation with a patient in need. Together, we complete the chain. Remedy Chain. Visit donatemymeds.org today.
All right, Donnie. So you mentioned Toyota and Lexus. And I think that's a perfect example because when you go as a family to go and shop for a vehicle, right, there's a real decision point you have to make. Like the luxury components of a luxury car are expensive, right, in general. And are you getting the return back for it for the investment overall is something you have to make a decision on. One thing that I'll play a little bit of contrarian for the question here is we are creating more and more effective Lexus drugs than ever before in the history of medicine. And so you have a number of medications that are extremely expensive. and they're extremely effective compared to status quo of these meds that are out there. So that's my first one for you, Donnie. When it comes to, let's just take somebody with diabetes. If you're looking at treating someone with diabetes 10 years ago, we have a lot of cheap drugs, right, to be able to utilize, and kind of a whole grouping of very cheap drugs. Today, you do not. Like if you're trying to follow guidelines, to follow best practices, you have very expensive medications to utilize that. And I know there's a lot of families out there struggling with that. What do I do that's best for me, best for my mom? If it's weight loss based, and you're talking about GLP-1s, for example, you've got a diabetic individual that's trying to decide, I know that I need to make these changes in life. I know diet and lifestyle modifications are necessary for me, and I'm struggling to be able to do so. And all the health benefits are there for this GLP-1, but it is so expensive. What do I do? So just using that as an example, Donnie, what do you advise patients when it comes to this new age of medicine? We're creating billion-dollar medications that are out there. We're not on a per individual basis, but from a market standpoint, you're looking at very expensive meds to take care of their loved ones. What's the next step?
It's a great question and an important question. One of the first steps is looking at patient assistance programs. Most pharmaceutical companies have patient assistance programs that will help offset the copay costs for some of these medications that are really expensive. That's part of market accessibility. So it varies depending on, how things will get delivered. In states like Louisiana, they have a Netflix type model for their drugs. They pre-negotiate certain medication costs for like hepatitis, so they have a guaranteed payout. So each state has their unique plans in terms of how they're setting up cost and offsetting costs for consumers, employers, and so forth. The Patient Advocate Foundation is an excellent resource that can help people navigate finding affordable options, whether it's going to be copay assistance or finding charity care. Patient Advocate Foundation operates across the whole U.S. They're based here in Virginia, and they have case managers that will work with individuals based on what their needs are, whether it's for the medications, housing needs, whatever they need. They have resources that they can help you find those type of things out as a solution. But as you pointed out, there are new therapies that are much more effective than what we've ever had before. But part of the biggest thing that we have to focus on is how do we balance those new therapies with lifestyle changes? And when we talk about diet and exercise, that's like the main staple for everything. But is food accessible? When you're living in a food desert, and if you have diabetes and you have no access to healthy sources of food, and then your doctor's providing you a handout saying, cut your carbs, eat healthy, more fresh fruit, more veggies. But if it's not accessible, then how well is that advice going, right? No matter how much of the new drug you give them, are they set up for success? This goes back to what I said earlier, knowing where your patients are coming from and understanding their need. Give you a perfect example. When I was practicing in Boston, I treated a lot of diabetic patients in my clinic setting. I had a patient that had a really high A1C, it's like 13. So we worked really hard in trying to get her A1C under control. And then she took the summer off. I didn't see her for a few months. She came back and I'm like, oh my God, your A1C is down to 9. Like, what did you do? This is great. We were just happy when she was from like 13 to 9, like to 10. But she went from actually 10 to like actually 7.5 or 8. It's been a minute. So I asked her, like, what did you do? And she's like, I went walking like you told me. I'm like, great. Where did you go walking? And she goes, oh, I walked in the cemetery. I'm like, what? Excuse me? She's like, yeah. I live in Boston and the safest place for me to walk is the cemetery because there's, flat roads, paved areas where I can walk. I feel safe because there's no gun violence because I was part of the neighborhood that she was living in. And I'm like, I just couldn't help be shocked by her approach. But I also appreciate the fact that she valued the work that we did together, knowing the right steps and things that she could do to help herself. And she found a way. And it was like, it's something it's easy to say, Kev, go for a walk, go walk 10 minutes. But if we don't feel safe in our own neighborhoods, that's not an easy recommendation. So we really do have to think about when we are making suggestions for our community members, what is their environment? What is their situation? If somebody's working 2 jobs, are you going to say, I need you to do more steps, Kevin? I need you to go do 5 miles. I need you to walk a mile. I'm already at 22,000 steps according to my smartwatch. How many more steps do you want me to take in a day? Right. So the suggestions for improvement for behavior change have to match up based on the individual's needs. And then the medicines are a part of that situation. It can't be a full replacement. And that's what we have to be honest with patients, is that the medications will help you only a certain way. And the goal is for eventually for us to start tapering these medications off. Some medications are indefinite. Some you can slowly wean off. but it's finding that balance. And that balance is something that we are all impatient people. As pharmacists, we're probably the most impatient. If I get a headache and my pain med doesn't work in a matter of a minute, I'm like, what's wrong? I'm like, I should know better as a pharmacist. Like, okay, Donnie, take some time to work. Like, give it a second. But it's like, no, I need this to work because I got to do stuff. So just think about it from our patient standpoint when they don't have the knowledge that we have, and their level of impatience it varies. So we really have to put ourselves in the other person's shoes and think about how can we help them find the best way to manage their illness based on their situation. And everybody's situation is different. I've sat down with patients and went through the dollar menu with them. If that's what you can afford, let's go through the dollar menu. Let's figure out how to make this healthy. I've taken patients on tours at Walgreens. If that's where your food access is, let's go shopping. Let's figure this out. One of the most surprising calls I ever got from a patient was, "Hey, Dr. John, I'm at the local blah, blah, blah bodega." I'm like, "Okay, I want ice cream." I'm like, "Okay, so why are you calling me?" "Well, you said to call you if I had questions. So I want to know which of these ice creams could I have?" And I'm like, first I was in shock and I was so excited. I'm like, "I love ice cream." But I'm like, "I don't know what you're looking at." So they, we talked about it, able to help make a decision. So that wasn't me trying to be a super clinician. That was just me understanding the need of that individual and just connecting with them and helping them where they wanted to do good, but they just needed a little help in knowing how to do it. And if we take a little bit more consideration, just those little things that where we humanize care, it could go a long way.
Donnie, I want to share a story of some of the things that you've been talking about in regards to the culture side of things too. And had a patient in the daughter caregiver was saying, we really have a hard time finding the carb levels for the foods because they were trying to figure out the number of carbs so they could figure out insulins, etc., for her mother. And I was like, oh, and I was just like telling her just basic, you can learn about the carbs through different things, Google it, whatever. She says, well, I've tried all of that. She said, we are in a certain area. And it was like, I would believe it was like Puerto Rico area. And there are different cuisines. And I said, all right, tell me exactly where. And me and the students are going to figure out what we can do for you. Come up with a list. And she says, good luck. And she gave us what she wanted. We tried and tried and tried, me and the students. And we're just like, she's right. They've really looked. We could not come up with some carbs for some of the foods that they were taking. And the best we could do is maybe a comparison to something, like just trying to figure out what was in there. So when you're talking about culture and you're talking about, different languages and things like that, what about different recipes, if you will, or some of these ideas? Like I was very shocked that I couldn't find a carb for some of the ingredients that these folks were using. So have you come across that at all, or have you seen different cultures and being able to find something?
Yeah, we do, as I mentioned, we do a lot of health education out in the community, and we teach a lot of different groups from children, adults, and seniors, and it's all different ethnic, backgrounds. So we talk about food a lot, and it's knowing the culture and really looking at what are healthy alternatives. So one of the things we do for our diabetes program, we have a diabetes education program that we created called Driving Education to Empower People. And it's really focused on lifestyle. It's seven modules, about an hour long each, that can be delivered in a clinical setting or a community setting. And part of that is really focusing on a lot on nutrition and finding happy balances. So we've created the education in English, Spanish, and Korean, and we're going to make it in other languages. For each community that we're working with, we focus the nutrition based on their ethnicity. And one of the cool things we do for the program is we ask the community to share with us their recipes, what they bring, what they find joy in. Then we take it as a staff, and we look at how do we make that recipe that they shared with us to be healthier. And then at the end of it, we make a cookbook based on their community recipes. We make a cookbook. It's called Sharing a Meal to Heal. And every community is different based on, the book. And we make them the celebrity chefs. Instead of having the Gordon Ramsay or Epicurus description of some random recipe that's for ethnic cuisine, well, let's take the recipe from the community and make them healthier. And when we give the community members the power to be the celebrity chefs and get recognized for it, their eyes light up, because someone took the time to hear and understand what are the spices they use, what are the different ingredients that they use to make their dishes. And you're absolutely right. It is very hard to find an easy, all-encompassing database that has the specific food. But this goes back to what I said earlier. Having a diverse team is extremely important, of staff and volunteers, where they can bring themselves to the table and understand, well, what is this vegetable called in your language? What is this called in your language? Okay, let's look at it. And then going to those countries of origin and thinking about, okay, what does their nutrition labels say in that country? And if you look internationally, in Mexico, for example, when I traveled to Mexico 2 years ago, I was so shocked to see that they had these unique stop signs as their nutrition labels, and it would tell you high sugar and all this other stuff. So I come back like, oh my God, look at this. And then someone travels somewhere else. So now everybody's looking at different labels as to how is the messaging being done in different parts of the world. Can we resonate that same messaging of what they see back home in their native country here in the US? In either Australia or New Zealand, they have a stop sign, the red, yellow, green traffic light. And that's how they have all their labeling done. And I know in the US, we've been reevaluating how to redesign food nutrition labels for a long time. But those type of things that people are doing globally have to make an impact. And most people are not going to go to your big grocery chains. They're going to their halal markets, the local bodegas, their ethnic stores. That's where they're getting their food from. Yeah. So, but how much education do you see being done in those stores? And that's really an area where we can do a lot more for engagement, because if we know where people are shopping, then let's target the messaging, helping people know how to become a savvier shopper as to here's 2 different products of the same kind, but this one's the better alternative for you, and here's why. So it's all about letting people know how to enjoy their food. Food brings us happiness. You can't limit that and expect someone to be consistent, because any diet is all temporary. When we talk about lifestyle changes, it has to be something that's tangible that they can continue doing ongoing. In our diabetes program, we had a mom participate in our workshop, and she went back, had her husband and son follow whatever she learned, and collectively they lost 110 pounds as a family.
Amazing.
The husband lost a significant amount of weight, so did the son, and the wife lost a certain amount of weight. But she took what she learned in terms of what are tangible things as a busy working individual. How can she make things change? And that's when we design education content. We think about that perspective as to looking at somebody that works 2 jobs or has very limited resources. What are the resources within their possession that they can use to make themselves better? Not something that we just think in theory. We don't need more white papers explaining that food deserts cause a negative impact, or, I forgot what I just read, that migraines can happen if you drink sugary drinks. I think we have enough white papers. We could have AI summarize all those white papers we want. We need to be more solution oriented, thinking about, okay, what do we change if we want people to be healthier, not just complain and regurgitate the same stuff.
Yeah.
Yeah, I feel like the regurgitation of information has been something that's interesting for, I'm sure, patients going in and seeing their healthcare provider and hearing, oh, all you need to do is diet and exercise. And that is about as hollow as it could possibly hit for everyone kind of involved. And the other piece is just, in general, we do as a society want something that's quick and convenient overall. Yep. And we're now valuing our leisure time, which is making up like 80% of our day, more than we've ever done before. Like now downtime is there. In fact, some people have kind of questioned the American dream of, you want to work hard enough so that you can stop working and do nothing. Like that is like a mindset. Like that's success. And so in general, when you're working with communities, Donnie, and that that you're fighting against that, like that mantra, that thought process, what are the things that you've done to be successful in order to help the folks that are falling into the exact same traps that are out there for current lifestyle and living, to be able to help them reorient the way their life can go and their health can proceed with it?
It's a simple question. What brings you joy? Try to find what brings them happiness and brings them joy, and trying to really connect with them as to finding out what's their motivation behind, whether it's quitting smoking or losing weight or anything. Once you're able to connect with what's that motivating factor behind them, then you really can connect the dots. And then you can figure out, how do you change behavior in a positive way where their motivation is that I want to see my kids graduate, I want to be more active with my children, I want to be able to travel. Well, how are we going to do that if you have a medical emergency, right? So finding those goals that you can set together based on what that individual is telling you is extremely important. But this is really where you have to be an active listener. You really have to take time to listen to your community members and their needs, and really connecting the dots accordingly. Not just, once again, guidelines are guidelines. And when we dehumanize the individual, we're never going to be successful. We're going to continue to have health disparities. There's 5 white papers you could find out about that. But what's the action going forward, right? And we just do research on research about stating the problem instead of identifying what are ways where we can have the conversation. How do we leverage technology so that way we can humanize our relationship with patients, connect with them, and not just send them a text message or send them referrals, but then there's no follow-up. Everybody has different tools and devices. They can get all these alerts, but if they don't know what the information is about, then it gets overwhelming. So it gets very frustrating. And from my perspective as a caregiver, I know those challenges, like so many other people that are kind of stuck in the middle of taking care of elderly parents and taking care of their own kids. When you're in that middle, pain points on both sides. So it's a matter of really designing thoughtfully.
Mhm.
And, when you work with different groups, that's part of the power of advocacy. You know how it can go, and it's your chance to, provide some feedback.
That's great.
Love that.
So I know that just to kind of take it back, I think we're coming in on our time, but speaking about the whole nonprofit world and what you do and what patients and caregivers can do, can you just summarize, no matter where people are in the country, what their steps would be if they are looking to try to figure out, how am I going to pay for this? What would you,
Yeah.
if you could just kind of just do a few bullet points as to this is how you should go about at least starting it and
Yeah.
just giving that insight.
So the first thing is go to a website called findhelp.org. It's free. As nonprofit leaders, we love free. Free is our favorite word. So it's knowing what resources are accessible and doesn't cost a thing. So Find Help is it's public facing, and it's like a social Yelp. You could type in your zip code and it gives you all the information you need for any of the social determinants of health, whether it's food access, housing, legal access. You can filter it just like you do on Yelp in terms of language preferences, income preferences. But this is a consumer-facing resource. And for us, we really focus on how do we empower the community, because we may not be around. So there's a lot of need, and it's about being self-sufficient. So Find Help, once again, it's a great resource. It's free, it's accessible. There's a paid version that's not, that can be used, but for the general public, the findhelp.org website is amazing. You can get everything you need right there from all your needs, and it filters, and they actively vet all the entities to make sure that their phone numbers work, their websites work, and that all the resources are appropriate based on where you're living and your zip code. So that's one. The second, as I mentioned earlier, was the Patient Advocate Foundation. Patient Advocate Foundation is a really helpful tool to help look at how do you offset medical bills, gain access to specialty medications, how do you have care management services, but it's nationwide. They do a phenomenal job in terms of really sitting down and helping individuals. You reach out to them, they respond fairly quickly in getting you the help that you need. But these are things that are going to make people really self-sufficient in helping themselves out and know it's accessible. The other thing to look at is there are over 1,400 free clinics and charitable pharmacies across the country. And the National Association of Free Clinics has a website where you could put in your zip code and you could find a free clinic or charitable pharmacy based on where you live. And the free clinics, the 1,400 plus clinics, see about 2 million people on an annual basis, and they provide some of the best care possible there, out there. They're the ones, as I mentioned earlier, providing care to those that are in medical deserts, pharmacy deserts. There's always a free clinic in every part of the country doing some amazing work. We're used to doing so much with so little. We need a lot more support, and from a funding standpoint, to continue the work. There's about 190,000 volunteers that come through free clinics on an annual basis, and there's about 16,000 people employed at free clinics. And these are some of the most dedicated people and passionate people that you could find that are really focused on serving the community, meeting the needs. And these free clinics can provide dental, vision, primary care services. Some provide specialty care. I don't remember which clinic it is right now, but there's one clinic now doing free surgeries for people that need operations. That just started. It was just there was just a news report about it. But the free clinics, I like to say that they're incubators of innovation. Out of necessity, they have to survive and think of ways of survival because their communities are dependent on them. So there's no option to fail. So we have to thrive. We have to innovate. But those are the three resources: findhelp.org, Patient Advocate Foundation, and then National Association of Free Clinic websites, where you could find access to care anywhere in the country. And on our website, the Nova Script Central website, we have a program called, we have a lot of programs. It's called MedHelp. And MedHelp is a free program across the country where people can type in an inquiry on our website, and in 2 business days, we help them to find the most affordable medication based on where they live. Because we only dispense medications to patients that are being seen in Northern Virginia at our clinic sites. But as we have a growing demand of people that have hard time affording their medications, we created this program as a free service that we know where to look. So instead of people using discount cards and going to multiple pharmacies and running the issue of polypharmacy, drug interactions, no one knowing what's going on, it allows us to do a brown bag. So you put in all the medications you take. We can tell you that you save more money by going for your medicines at this one location versus going to 3 different locations. But in 2 business days, will provide a response with the 3 most affordable options based on where you live, whether you live in South Dakota, Minnesota, or Texas. We can, our team knows where to look. And then we try to help people in answering their questions, whether you have insurance or no insurance. We'll tell you, here's what's on your formulary. You should talk to your doctor about this. Or, hey, one of the medications you take is for a cough. You may want to talk to your doctor about it. We're not going to tell you to stop something, but it's more of just giving you the information needed to help you make a better decision.
Right.
Amazing. I got one final question for you, my friend, before we end the episode, which it just absolutely flew again. It's this one. What's the one problem that you've run into that you could not solve for someone, that was difficult to be able to say, I don't know, that you hope tomorrow, the next day, next year, we can say yes to?
Wow. That's a tough question. That is a really tough question, because I don't know if I could have a simple answer. I think it just comes down to, some of these rare diseases and families that need support, where, you talked about some of the newest drugs costing a considerable amount of money.
Yeah.
How do you get people access then when the drugs are so unaffordable or it's out of reach? How do you help people get connected to a clinical trial? And that's one of the things that we try to advocate for, is how do we increase clinical trial awareness, getting people to understand that clinical trials are important. And they might sound scary, but there's a lot of great people that work behind the scenes to make clinical trials accessible. So I think that's the biggest thing that I've been working on as of late, is looking at some of these rare diseases and these conditions. How do we connect people to the right clinical trials so they have treatment through a clinical trial as an opportunity, where some of these stories are just really hard to hear, because you want to help everyone, but it's not feasible. And it's looking at, can you do things from a system-wide level that can make slow changes, where eventually long-term game plans of making sure that clinical trial participants are having access to drug medications afterwards, looking at what the long-term perspective of that looks like.
I love it. Yeah, aligning incentives to help humans. That's a beautiful way to kind of end this episode. And thank you all for joining. Any other kind of questions? We'll post some of these resources that Donnie is gladly kind of put them in front of us so that folks can utilize them and hopefully leverage them for their care. Thank you so much for Remedy Chain for their partnership and for advocating for these very similar things to what Donnie is doing to get medications in the hands of those individuals that couldn't afford them otherwise, and creating a resource for that. You can find us on YouTube. You can find us on LinkedIn and Facebook and Apple Podcasts and Spotify. And so we will see you guys there. Any other questions or anything else comes up, you let us know, and we'll see you on the next episode of the Med List.
Thanks, everyone.